Well, good morning to everyone. Thank you for joining us this morning. We are excited, not just to be in wonderful, beautiful Orlando, Florida, but to be marking on our journey, and this is our very, very first journey on the road to helping and identifying and working with communities and doing some work on geographic health equity. This is our first symposium in this area. We're excited about it. We couldn't be more pleased than to be working with CDC in this area. So thank you for being a part of our first symposium that addresses geographic health equity. So as you have seen in the program, where you live matters as it relates to your health, and that's what we're going to be talking about to a great deal today. So I'm so happy to see so many of you as we focus on specifically tobacco and cancer as it relates to this issue of geographic equity disparity. As you all know, and I don't need to tell anyone, that tobacco remains the #1 cause of preventable deaths in the U.S. I don't want to get off subject too much, but I was just talking to my good friends that I will introduce later from Wake Forest, that I've had two very close friends in the last year pass away as a result of tobacco. One was a great friend of mine that I had served in the military with for many years. He was 65 years of age. He had retired. He had gone to Raleigh, North Carolina, accepted a job at a university. His wife was a principal. He had 2 grandkids. He had his retirement home, and he's now passed away at the age of 65 because of tobacco. The other one was a young lady. Oh, come on in, everyone, please. It's okay. Come on in. We'll help you find some seats. There's plenty up here in the center and over on this side. Good morning. Okay, I was just saying that tobacco continues to be the #1 preventable cause of death in America, and I was telling them about a couple friends that I have personally who passed away as a result, and I had just finished, as you were walking in, telling them about a young man who was the age of 65 that I had served in the military with that passed away. And the second one is a young lady that was only like 53 or 54. Had a son and had been a college friend of my wife when she passed away a few years ago as well, all because of tobacco, which is so unfortunate, but it is happening, and as you get older, you will also start experiencing the same kinds of things that I have experienced, which is unfortunate. But due to our concern about this issue, CATCA is honored to have been selected by CDC to operate a national network organized to focus on states and local communities experiencing tobacco and cancer-related geographical health disparities. So we're excited about that. It's something that is a new adventure for us, as I said earlier. And as a result of our continued partnership with CDC, US to our portfolio is the Geographical Health Equity Alliance. So we, in the process of entering into this grant, we actually created an alliance. We gave it a little logo. We housed it on our website, and this is the first symposium that alliance that is hosting as a result of our work with CDC. So the Geographical Health Equity Alliance, and I'm just going to call it the Alliance now, is a national network of coalitions, state programs, public health departments, national organizations, researchers, and other community-based agencies dedicated to addressing tobacco and cancer. That's what we're all about, related to health disparities primarily determined by the geography of where you are located. So throughout our This 5-year initiative, and it is fortunately a 5-year initiative, CAT will work with its partners, advisory council, and network members to identify gaps in the information. We're going to provide leadership and expertise to the field and promote health interventions that support the appropriate partnerships to reduce geographic health disparities, particularly in the southern states, primarily the southeastern southern states of the country. So I'd like to pause now to recognize some of our partners that we have with us in the room that are supporting this important work. And I want to start with the great friends from Wake Forest School of Medicine. If I could have the team members from University of Wake Forest, or Wake Forest University, not University of Wake Forest, please stand up so we can recognize them and thank them, please. We are also extremely excited to have such wonderful speakers here today. I think she'd like to be called Kate Weaver instead of Catherine Weaver, is that correct? Going to be one of our speakers, and we're excited that she is here with us. We're also going to have Dr. Erin, is it Sutphin? There you are. Thank you for being one of our speakers as well. We're excited about that. And all from Wake Forest. Where's my good friend I just met this morning, but we had a phone call last week, Dr. Chris Fulcher. Chris, thank you for being here this morning as well. You're going to bring to us some very insightful information. I got a preview of what he's going to share with you all earlier, and I'm telling you, it is a wealth of wonderful information that will benefit all of you. So you're going to be very excited to hear his great work and what he has to bring to us, and coming from the University of Missouri. So thank you for being here, Chris. Thank you very much. Also, we have here, is it Shandy Keefe? Is she here this morning? I don't see her this morning, I don't think. But she's from the National African American Tobacco Prevention Network, and she should be joining us later this morning and is going to give us some information as it relates to that particular community and its challenges related to tobacco and the problems associated with tobacco. So we're excited about that as well. Also, we're going to have a wonderful panel this morning of speakers, and that's going to be exciting and going to be very informative for you as well. And the panel members are Carol Dickens. Is Carol here this morning yet? There she is. Carol, thank you for being a part of that. From the, is it Wealthy Journey, out from Memphis, Tennessee, right? So thank you for being here as well. And then we will have James Allen from the Oklahoma Department of Mental Health and Substance Abuse Services. James, are you here? Thank you for being a panel member. And we have, this one's is a mouthful, but Travis Hamondala. Is that pretty close? That's it. I got it right? Who is the director of the Southern Coalfields Tobacco Prevention Network in Southwest Virginia. So thank you for being a panel member as well. Good. Excited to have you here. So in preparation for today, we did some intensive work and training. The CATCA staff, along with our partners, have been working diligently to build for you a symposium that will be long-lasting and one that will be helpful to you as we enter into this great work. We believe it's important work. We think it's a wonderful nexus to the work that community coalitions do back in their communities on a regular basis to help understand and deal with tobacco, particularly as it relates to cancer and the challenges associated with where you live. is important to us to deal with that, and we're excited about that and look forward to having a wonderful day with you here in Florida. Most of you know that we are a private association in Washington. We are 22 years old now. We're excited about that. We have been going into communities from the very beginning to build skills and competencies into local community people so that they might own and solve their problems. All communities are unique and very different, but yet we understand and believe that they all deserve the support that we can bring to them from Washington, from the state level, county level, and then I like to say, let's just kind of get out of the way after we have built skills and competencies into the local people, help them identify what their problems are, and let them then go to work utilizing the models and the skills that we put in place to solve their problems. And this issue is really no different than that. That's the approach that we have taken for years. We think it works best when community members solve community problems. All local communities, we like to say, deserve local solutions, but they all deserve and need the skills necessary to make that work. And that's what we want to do in this effort, working with CDC to highlight those problems as well. We want to thank you for being here. We want to thank you for getting on this journey with us as we journey off into a new area of work that we think is critical and important. We believe that where you live does in fact have an impact. Now what can we do, what can we bring to bear to help mitigate the problems associated with your geography so that we can help you identify the barriers and the challenges, the risk factors, and then put in place the appropriate protective factors to help these communities solve the problems, particularly as it relates to health and tobacco. So have a great day. Enjoy your work. We appreciate you coming to Florida to spend some time with us. We know we had to twist your arms to get you here, but enjoy yourself. And a few of you had the opportunity to come in early. I had some chats. That's good. And a few of you are going to be able to stay the rest of the weekend, and that's wonderful as well. So have a great week. Thank you again for being a part of this and for helping us step off into a new adventure, which we think is critical and necessary for this country. Thank you very much.
Okay, so I will be introducing our first speakers. You all have our speakers' bios in your workbooks on page 59, and so I will not read that in detail because I know you all are excited to dive into the content. But first up, we will have Dr. Kate Weaver and Dr. Aaron Sutphin. They are both from Wake Forest School of Medicine. They have some very exciting information to share with you all today, and here's a brief, some of the points from their bios there that you can also read. But without further ado, I'd like to have them come on up and start their presentations. Thank you.
Good morning. It's really a pleasure to be here today for the first Geographic Health Equity Symposium, and we hope that this is going to be a great time of learning for all of us. So, the goal of our talk today is to really set the framework for what we're about to discuss today. And how many of you are familiar with the term geographic health equity? Or were before you moved in? All right, well, so you were further ahead of where I was 2 years ago. This may be a new concept for a lot of people, so we want to present some initial ideas around framing health disparities issues in terms of geography. So we hope to convince you that, in fact, geography does matter for health and does impact your health and your well-being. And we want to provide some examples of geographic health disparities in cancer and tobacco. So first, we feel like there's a knowledge imbalance, is that you now know more about us, the speakers, than we know about you. So I'd like to just do some quick polls, raise of hands, so that we can get an idea of who you are and the groups that you represent. So first, I'd like to know how many people in here primarily are involved through their connection with coalitions, either as members of coalitions or leaders of coalitions. Excellent. How many are primarily researchers? A few researchers in the room. How many work with public health departments or other local health agencies? Great. Did I miss any important categories? Anyone? Youth in training? Excellent. You're the future of our field. I'm so pleased that you're here as well. And the other quick poll I want to take is the issues that your work has primarily been focused around. So how many tobacco folks do we have in the room? Excellent, lots of tobacco. Cancer? A few cancer, okay. Substance abuse? Some substance abuse. Other kind of general health? No specialty? Okay. So that's really helpful to us in understanding your interest and your focus, and hopefully we can tailor some of our work to what you're most interested in. Oops. So starting with a very basic definition of health. Oops. Sorry, I'm having a little clicker problems. The Alliance defines geographic health disparities as differences in health behaviors or health outcomes that are related to where people live. And this is a very basic definition, but this is at the core of what we mean by geographic health disparities. So we want to start our presentation by simply asking the question, does geography matter? Is this something we should be concerned about when thinking about health issues? So we'll go straight to the top, the CDC. And this quote was just from a couple of months ago, and it really resonated with all of us. So this is the head of the CDC, Dr. Tom Frieden, and he was quoted in several major publications. When it comes to health in this country, your longevity and your health are more determined by your zip code than they are your genetic code. And I really think this speaks to the importance of the topic we're all here today to discuss. I'm sorry, I'm having problems with the clicker. So we just want to provide a few quick examples that will hopefully convince you that in fact geography matters. So this is an example from New Orleans, and you can see the differences in health outcomes just based on neighborhoods that aren't even a mile apart. So we have the 7th Ward here, where the average life expectancy for a child born in the 7th Ward is 66 years. Compared to this neighborhood up here in Lakewood, where the life expectancy is 80 years. And you can see, again, these are only maybe a mile or two apart. And also, and even lower in the French Quarter area, children born there can only expect to live to be 55 years old. And we think, what an interesting phenomenon, and yet how sad that where you're born in a particular city has such a strong influence on your health. And just a second example, anyone from California here? All right, we have one person. So you may know these zip codes better than I do, but this was an example. California has an initiative now focused around health happens here, focusing on this issue of geography and health. And so they compared 2 zip codes in California and the life expectancy of children born in those zip codes. The one on the left is Compton, and on the right, I believe, is a very Tony area near Malibu on the beach. And you can see, again, 15 years difference in life expectancy based on where you live. So just a quick note about geographic health disparities and other disparities. So many of you may have had many of your disparities work focused around the issues of race and ethnicity. And we would just want to point out that geographic health disparities certainly are not isolated, and that because of the strong residential segregation that we often see in our country, both by race and ethnicity and poverty, that in fact geographic disparities may reflect other disparities and may reflect underlying differences in the population that reside in these areas. So certainly by race and ethnicity and health insurance and poverty, those all vary by where you live. But they may also exacerbate other disparities, and we see this, and sometimes it's called double disadvantage. So for example, one of the African Americans who live in rural areas of the countries may have compounding disadvantage compared to African Americans who live in more urban areas, and also compared to to whites who live in rural areas. And really today, and I think the Alliance in general, is going to be a test of this hypothesis. Is geographic disparities a useful way for framing some of these questions? And does it encourage new people to be involved in our quest for health equity? And is it a useful way of exploring these problems that we see in our country? So we hope that you will in fact agree with us that geography does matter for health. So I probably don't have to convince anyone in this room that, in fact, tobacco and cancer are major public health problems in our country. Cancer is the #1 or #2 leading cause of death in every one of our 50 states. It sort of flip-flops with heart disease, but will probably eclipse heart disease because we've been doing a better job in some ways of controlling heart disease than we have of controlling cancer. And there are 13.4 million US adults living in our country with a history of cancer. So just quick show of hands, how many of you have either been impacted by cancer yourself or have had a close family member impacted by cancer? Everybody in the room. There are 1.7 million new cases of cancer every year in our country, and more than 500,000 deaths. And this statistic, I think, is staggering every time I look at it, that over the course of their lifetime, 40.8% of all men and women in our country will be diagnosed with some form of cancer. Tobacco, as many of you know as well, is the leading cause of preventable death, and actually contributes a good number of the cancer cases that we see. And again, almost 500,000 preventable deaths every year in our country, in addition to kind of staggering costs in terms of medical costs and lost productivity. So to get started framing around the issue of geographic health equity, we want to just show maps of the United States and mapping both the cancer death rates and the tobacco use to show you the tremendous variation that we see by geography in terms of these two critical public health issues. So you can see that, and this is death rates from cancer, and that the varying areas of our country vary widely, with the lower rates in the West and the highest rates in the Southeast, which is the region that we are most particularly concerned about. In particular, this area of the country is often called the stroke belt, but we see you might as well call it the cancer belt, because certainly they also have a disproportionate burden of cancer in these areas as well. So again, looking at adult smoking prevalence by state, again, we see tremendous geographic variation with the lowest rates in California and Utah. And again, higher rates, I think not by coincidence, in those same areas of the country that are disproportionately burdened by cancer are also burdened by higher rates of tobacco use amongst the adults who live in those states. So take a quick look at your state and find out how your state is doing both on cancer and tobacco. Out of curiosity, how many folks in the room are from states who are in the darker shades for cancer or tobacco? I am in North Carolina. Yeah. And we had one person from California, which is doing well on both. So why does geography matter? And we want to spend a little bit of time to introduce you to a conceptual model that we've developed to really unpack why we think geography may impact both cancer and tobacco use. So for those of you who want to take a closer look at the model, it's printed in your book, and as well it's on the table in the back. But briefly, we want to reflect the many layers that may influence geographic health disparities. We realize it is not one cause, it's not one factor, but in fact it's many, many factors that are layered together that ultimately influence the rates of cancer in one community versus the rates in cancer in another community, or maybe even neighborhoods in the same community. When we start at the very center of the model, at biology. And we're not going to spend a lot of time talking about biology today, but we just want to acknowledge that, in fact, these are medical conditions or health behaviors can be influenced by biological factors like genetics and other medical conditions. Moving up a level, we focus on the level of the individual. And certainly there are individual choices that people make, health behaviors that folks engage in that influence their tobacco use and their cancer risk, as well as demographic characteristics that also influence their health, as well as their socioeconomic status. Moving up one more level, and that's when we're moving into the level of the social context. So what we're talking about is humans are social creatures. We don't live in a vacuum. We interact with other individuals. And these individuals influence our health, both in positive and negative ways. This also refers to the general social atmosphere that we may find in. Do individuals in your community smoke? Do individuals in your workplace smoke? Do individuals in your family smoke? That certainly influences your risk of smoking yourself, as well as general health behaviors that influence your cancer risk. We also see this with regards to beliefs about health. So what do people in your close social network think about cancer? Do they think that it's treatable, that if you seek early attention, that you could be cured of your cancer? Or do they think that it is a fatal disease? Do they talk about cancer? Do they talk about other substance use? Moving up one more into physical context. And this is really important in geography, and oftentimes people think about the built environment and how that might influence people's health. How many of you live in a neighborhood with sidewalks? Wow, that's great. We have no sidewalks in my neighborhood, which certainly influences the degree to which you might feel safe going out to walk your dog, to get some physical activity, or that you might feel safe letting your kids walk to school if there's a sidewalk that keeps them off the street. How many of you live within a mile of a convenience store that sells tobacco products? So there's another factor that influences our neighborhoods and how convenient it is to get tobacco products. There are other, certainly sometimes we think about cancer hotspots, or people worry about pollution or air quality or those sorts of things, and those can also play into geographic health disparities. And finally, we have what may be one of the most critical factors for your health, which is the political and economic environment. So this refers to who lives in your neighborhood. It's not just your income and your ability to access health insurance, but also the people around you may influence your health. Do you have access to care? Can you get to a clinic or a hospital to provide care? What are the state and local policies around cancer and tobacco that influence you? How many people live in a community that has a comprehensive indoor Clean Air Act that bans tobacco use inside? A good number of people, but not everybody in the room. I've moved around this country and realized the tremendous variation that exists with regards to clean indoor air laws. So we want to provide just a few examples around geographic disparities in cancer and tobacco to just get you thinking about problems that may exist in your community and hopefully stimulate a little interest to start tackling some of these issues in your community. So, brief background, I saw only a few fellow cancer people in the room. So for the rest of you, I want to just provide a little bit of information about comprehensive cancer control and what we mean by that. And that's a process through which communities and partner organizations work together to really comprehensively address cancer problems. And the goals of these efforts are to reduce cancer risk, so reduce the risk of people of ever developing a cancer, to find cancers early when they're more treatable, to improve treatments for those individuals who have cancer, to increase the number of people who survive cancer. We want more than 13.4 million US cancer survivors. We want all of those folks to survive. And we want to improve the quality of life for survivors. And we also often talk about the cancer control continuum, and this can be, I want you to just focus on the top for now. And this is useful for understanding when you have a cancer problem, where in the cancer continuum is it occurring. On the far left is prevention, and these are efforts we take to prevent people from ever developing a cancer in the first place. And I bet everybody in here could name probably the number one thing that you can do to prevent yourself from ever having a cancer. Quit smoking, exactly. That is the number one thing that anybody could do to reduce their cancer risk. But we also are increasingly understanding that factors like diet and physical activity, sun exposure, exposure to viruses, the HPV vaccination is another way that we can prevent people from ever having a cancer develop. And alcohol use even, and then now there are a few cases where you can actually take medicine, a medication that reduces your risk of a cancer developing. Moving on, we have early detection, and this is often where a lot of our cancer efforts focus. We promote things like mammography, like colorectal cancer screening, like PSA testing. These are all tests that do not prevent cancer, largely, but they are early detection for cancer. So we find cancer when it is more treatable, and we are able to cure it many times. Moving on to treatment, we want to make sure if people are diagnosed with cancer that they have access to good quality care, that they get an appropriate treatment, and that they can access it. And finally, survivorship, which is where I spend a lot of my time focused, is on ensuring the best possible quality of life and health for those individuals who've had a history of cancer and who have been treated for it. So I want to spend just a little bit of time narrowing down to talk about one cancer. For those of you who are in cancer, you'll know that although we talk about cancer as a general problem, in fact, it's probably 1,000 different diseases, all of which are slightly different. So we want to focus on the problem of colorectal cancer today. So why is colon cancer a problem? Well, it is the third most common type of cancer for both men and women. It's actually a misconception that we've seen often in our community that only men get colon cancer, but men and women get it. And there are approximately 50,000 deaths per year in the country from colon cancer. The wonderful thing about colon cancer, if there is a wonderful thing about it, is that it can be prevented and successfully treated if it is found early, and we have extremely effective screening tests for this disease. So again, looking at our maps, you can see that incidence rates for colon cancer vary greatly in our country. Again, some of the states in the Southeast have the highest rates of colon cancer, and also in the Midwest. And in fact, this may be related somewhat to use of screening tests for colon cancer. So this map is our screening tests. And we see it doesn't map perfectly, but some of the states that were red with the highest incidence in the last map are also some of the states that have the lowest use of screening tests for this cancer. Again, you may want to take a look at your state and see how you stack up. How many are in red or orange states for colon cancer? And just to show you that we're not just talking about state by state, but that in fact there's a tremendous amount of variation within states. And we're going to see later some examples of variation within states. But this is North Carolina, where Wake Forest is located. And you can see that we have everything from dark blue with the lowest rates of cancer to dark red, the highest rates of cancer, right in our own state, varying by county. So there can be, those state maps can often mask important variation within states. So we want to apply our geographic health equity model to the problem of colon cancer. So again, this is our model. And we're going to walk through step by step, starting with biology in the very center of our model, orange. And there are, in fact, genetic predispositions to colon cancer, and there are medical factors that influence your colon cancer risk as well. For example, if you have a history of inflammatory bowel disease. Moving to the purple individual characteristics level, we know that choices that individuals make influence the risk of colon cancer. Both alcohol and cigarette use are risk factors for colon cancer. Many people don't realize that. And as well as lack of exercise and obesity are also primary risk factors for colon cancer. We also understand that there are race and ethnicity disparities in colon cancer, that colorectal cancer rates are highest in Black men and women. There's a lot of reasons for this, but it's an important part to consider when you're looking at individual risk. As well as health literacy. We've been doing some studies and we've found that individuals who have a hard time understanding medical information, they can't easily read medical forms, they often have a higher risk of colon cancer, likely because they don't engage in some of these preventive health behaviors and or screening. So we also know that social context influences colon cancer risk. So in terms of social norms, do you talk about cancer in your family? Do you talk about being screened for cancer? Is your view of a cancer patient the woman on the left or the woman on the right? These are both cancer survivors. There's often embarrassment factors relating to colon cancer screening. People don't like to talk about colons or rectums. They don't like to talk about the process of being screened. And then there's myths, as I mentioned, a belief that we have seen this in the focus groups in our community, that people thought that it's a man's disease, that women don't even need to be screened. And we've often found that social support is a really important factor for getting people screened for colon cancer. Married men are much more likely to be screened for colon cancer than are unmarried men, likely because they get support for screening from their wives. Maybe their wife makes the appointment for them. I see some recognition in the room that this is in fact the case. Maybe I should do a poll of hands if you're a wife and you've made a medical appointment for your husband. So what are some of the physical environment factors that might influence one's risk of colon cancer? Well, as we were talking, people live in different built environments. Our neighborhood characteristics vary. So are there walking trails nearby? Do you have sidewalks? Do you have places in your neighborhood that you might want to walk to? Where's the closest gym to your house? Can you easily get there? Or is it way on the other side of town and not convenient? How many of you have heard of the term food desert? Almost everyone in the room. That is an amazing geographical construct that I think has just exploded in the last 10 years, where we understand that there are some people who live in communities where there is not a single place to buy healthy food within the vicinity of where they live. And how do you think that influences people's ability to access a healthy diet, to eat fresh fruits and vegetables, if they're not available anywhere where they live? We often look at the travel distance to obtain screening or treatment. So I do a lot of work focused on rural populations. And individuals who live in rural areas may have to travel a very long distance to get either treatment or screening. Colonoscopy, which is one of the primary screening tests for colon cancer, is done by endoscopy. It needs anesthetic, and it's often done by a specialist. So those individuals may have to travel a long way to get a colonoscopy. And finally, talking about the outermost level, the political and economic environment. Can individuals in a community access care? And by and large, this is a factor of the political and economic environment in which they live. Are they living in a state that accepted the Medicare expansion? How many of you live in states that did not accept the Medicaid expansion for the Affordable Care Act? I do too. And it's important to point out that the Affordable Care Act would have provided colon cancer screening tests at no charge to people with private health insurance in those states. And certainly it would provide increased Medicaid coverage would also influence people's individual ability to access screening. What's the cost of medical care? What are the insurance rates in your community? And then there are also important federal policies that influence colon cancer screening. The CDC runs a colorectal cancer screening program in which they provide supplemental funds to access colon cancer screening. And I'll show you the states that are involved in them, but it's not universal coverage. So just to take a look, this is the states in dark blue are the states that are highest on the percent uninsured in our country, where it's exceeding over 18%. Quick show of hands if you're in a dark blue state. And these are states that are, the states in blue are those that are participating in the CDC colorectal cancer control program, in which free or low-cost colon cancer screening is available to individuals without health insurance. And again, you can see that this program does not cover the majority of states in our country. So we want to provide some examples, just thinking a little bit that you want to match the intervention to prevent cancer or tobacco use with the appropriate level. So some examples of individual targeted interventions, and I think these are most of our work in cancer is, we provide educational materials to people, we try to get them at a screening fair, we do public health campaigns, but then there can also be more community-level interventions where we're not targeting individuals so much as whole communities. So we think about community organizing, partnerships with hospitals and clinics to improve access, and policy interventions, all of which influence the health of individuals in the communities. So we want to provide a very quick case study. And so much of the time when we talk about health disparities, it is a litany of identified disparities, and it can be actually quite demoralizing to just hear more and more about how there are these persistent disparities in our country. And we wanted to talk about the case study of Delaware because I think it provides a bright, shining ray of hope for how we can eliminate health disparities in our country. And the journal article that wrote up this example is actually provided to all of you in your materials. So I hope, not right now while I'm talking, but later today, maybe on the plane ride home, you'll have a chance to really read this article. Even though it was published in a scientific journal, it's very readable. Some of our stuff is not, I realize. And I think it's a tremendous example of how if people are truly committed to working to eliminate health disparities, that they can do it and they can be successful. So in 2001, Delaware had a big problem. They realized that African Americans in Delaware were more likely than whites to not be screened for colon cancer. Less than half of the African Americans in the state were screened versus almost 60% of the whites. But you see, that's not good for either of the groups, actually. African Americans were more likely to be diagnosed with colon cancer and were more likely to die of colon cancer than were their white counterparts. And you may say, well, this sounds like a race and ethnicity disparities problem. How is this a geographical health disparities? Well, I think it was really critical because Delaware framed the issue around their state. And they said, this is a state problem. This is our community. This affects the people where we live, and we need to address it. And importantly, the disparity that they saw in Delaware was larger than the disparities seen in the rest of the country. So they realized there's something about our community and where we live in our state that we need to address. So in Delaware, in 2002, they established a state advisory council and a cancer consortium to work on this issue of colorectal cancer disparities in Delaware. And they worked, there were community advocates, there were state legislators, the governor was involved, there were public health organizations, and they all worked together, and they had one goal. They said, we want to eliminate disparities in our state with regards to colon cancer deaths. And so they established the State Advisory Council, and the goal of what they decided they needed to do was they needed to increase access to screening. Everybody in the state needed to have access to a colonoscopy or an FOBT test to detect colon cancer early. They needed to increase the knowledge about colon cancer, because it's not enough just to offer the screening test. You need to get people in. People need to know that this is an important thing to do, and they need to be willing to do it. And then they also needed to increase receipt of treatment, because they found even when people are diagnosed with cancer, sometimes they don't get appropriate treatment. So they established the State Advisory Council, and they decided, all right, we're going to cover the cost of colonoscopy screening for every uninsured person in the state. We'll pick it up through the state program. We're also going to hire a cancer screening nurse navigator and a care coordinator, because we know we need to get people out in the community. We need to talk to people about colon cancer, and we need to solve barriers to care. So if somebody can't get in, we need to find them a ride. If they don't know how to do the prep, we need to talk them through the process. If they don't show up for their appointment, we need to find them and get them to come back in. They did targeted outreach to the African American community, primarily through these nurse navigators. They got people out in the community in fairs talking to individuals. And importantly, they covered the cost of cancer treatment for anyone whose cancer was discovered through the screening program and it was not just the insured, they actually covered people up to about 400% of the poverty level to ensure that somebody would not be bankrupted if their cancer was detected through this program. So what happened? What were their results? Well, in 2001, on the left, you'll see that among the African Americans who were diagnosed with colon cancer in the state of Delaware, only about 15% had their cancer detected at an early stage when it was most treatable and their survival would be the best. And look at the difference in 2009. The comprehensive program was implemented in 2002 to 2003. Within about 6 years, they had increased the percent diagnosed at an early stage to 50%. I think if we did this at a nationwide level, we would change the face of colon cancer in our country. And probably what people care about the most, did we prevent people from dying of colon cancer? You see here in 1999 to 2001, African Americans are shown on the yellow line, and whites are shown on the gray line, and you can see the tremendous disparity that existed in deaths from colon cancer when they started this program in 2001. And they implemented it again in this time period, and you can see that the rates actually go down for everyone in the state. Everyone benefited from this program. But most importantly, the disparity shrunk, and at the end they concluded these two rates were the same. Statistically, you couldn't tell a difference between these two rates. They eliminated the disparity in colon cancer mortality in their state, and they did it in about 6 years. So I would be remiss if I didn't also tell you that there was a tremendous financial case to be made. Importantly, the governor of the state and the state legislature fully funded this colon cancer program. That's critical. And they funded it at a cost of $1 million per year for screening. And that ended up to be about $1.15 per person in Delaware. I think that's a pretty good bang for your buck. In addition, I told you that they covered the cost of treatment for anyone whose cancer was detected in the screening program. That cost them about $6 million a year. So we see that the whole program cost about $7 million a year. They estimated that they saved $8.5 million per year from reduced cancer incidence. Some of these cancers, they prevented them from ever happening because they took out a polyp that would have developed into a cancer. They took it out. This person never got cancer. And they moved the stage towards more treatable cancers that actually cost less to treat. So they saved $8.5 million for a net of $1.5 million that they saved in this state because they implemented this program. I think this is really important data to provide to our leaders, that you could actually save money by doing the right thing and eliminating health disparities. So I hope that that was a really powerful example to share with you and hopefully get you excited about the possibilities of when geographic health disparities are identified and a committed group of individuals works together, that they can be solved and eliminated, and money can even be saved in the process. And without further ado, I'm going to hand over, I think we're going to hold questions until the very end, but I'm going to hand over to my colleague, Dr. Erin Sutphin, who's going to talk about geographic disparities in tobacco.
Kate, which of these clickers are you using? Okay, great. Good morning. Thanks, Kate. So Kate gave you a little bit of an overview of geographic disparities in tobacco use, and I'm going to dive in a little bit deeper into this issue. As Kate mentioned, there's a goal, a continuum of cancer control, and similarly, there's a continuum of comprehensive tobacco control as well. So the goals of comprehensive tobacco control include preventing youth initiation, promoting quitting among adult smokers and youth smokers, eliminating exposure to secondhand smoke, as well as identifying and eliminating disparities among different population groups. So you saw this map at the beginning, and this shows smoking prevalence among adults by state, and those in the darkest green are those states that have the highest prevalence, and the lightest have the lowest. So Kate pointed out California and Utah that have the lowest smoking prevalence, and you see the darker greens largely in the southeastern states. There's also differences in smoking by where you live, whether it be rural or urban. And so this graph shows the red bars in the back are the rural areas, and the lighter bars in the front are the urban areas. And in almost every case, this shows both by gender as well as by age. And almost in every case, those living in rural communities have higher rates of smoking than those in urban communities, with really the exception of those 65 and older, which are pretty much equivalent. So not only where you live, in which state you live in matters, but also where you live within your state, which community matters as well. And we see differences by smoke-free air laws. So exposure to secondhand smoke differs greatly across the U.S. And what this map shows is places where smoking is banned. So the lightest colors show that there's no statewide smoke-free ban. The green, the darker green, shows that smoking is banned in most indoor workplaces and public places, but not bars. The yellow shows, in North Carolina, where I'm from, shows that smoking is banned in restaurants and bars. And then in the green, it shows it's banned in workplaces and restaurants and bars, the lighter green. So you can see large disparities across the states in exposure to secondhand smoke. The place where you see virtually no disparities is in how much states are spending on tobacco prevention and control. So virtually all states are spending less than 50% of what the CDC recommends. So this is the one disparity that we actually wish we would see some increases across states, but there's very little difference in what states spend. So let's take a minute to walk through the model and apply it this time to tobacco. So this is, again, the model that you saw. As Kate mentioned with cancer, in the innermost circle of biology, there are biological differences that may contribute to tobacco use. So for example, genetic predispositions to nicotine dependence. But nicotine also changes structures in the brain. So this image here shows that different areas, wrong one. That's it. Show that different areas of the brain light up over the time that you are smoking cigarettes. And there are also differences in smoking based on if you have medical conditions. So for example, substance use disorders. So we know that folks that have substance use disorders are much more likely to smoke. Individual characteristics also, of course, influence smoking, and these differ by where you live. So alcohol and other drug use among youth, sensation seeking tends to be a predictor of smoking. And then your socioeconomic status. So this image here shows that people below the poverty line have a much higher smoking prevalence than those who are at or above the poverty line, so 29% versus 18%. So going out to the next circle in our model is social context. And we know that, as Kate mentioned, we live within communities and we live within our networks of our neighborhoods and our peers and family. And so how peers and family think, and those in your community think about tobacco and tobacco use is going to influence how an individual interacts with tobacco. So you've got role models, people who are using tobacco around you, but also culture is really important. And as you've heard us say several times, not only are we from North Carolina, which is the largest tobacco producing state, but we're from Winston-Salem. Winston-Salem is where R.J. Reynolds is headquartered. So our community and the culture of our community is very different from where I'm from originally in New York. So we've got very strong ties to tobacco farming as well as tobacco production. And literally, this is the image we see out of our front door. I don't know if you can see that very well, but it's the smokestacks of an old manufacturing plant that has RJR tobacco on it. And we see images like this all over Winston-Salem. Where our kids go to Ronaldo High School. We live near Ronaldo Road. It's very embedded in our culture. And so how people think about the product and use of the product are very different in Winston-Salem than if you go to other parts, even in North Carolina, and certainly to outside of North Carolina. So culture really matters for this. And then physical context also matters quite a bit. Kate asked earlier how many of you would live within a mile of a place where you can buy tobacco. So we've got access to tobacco, and then we've got exposure to advertising. So you can be exposed to tobacco advertising just by driving by a place. And then, of course, if you decide to go into a place here, and if your kid wants to take a ride on this little car, they can check out the sales for tobacco products within the stores. And then I'm going to talk a little bit about tobacco retailer density. So there's a lot on this graph, so let me walk you through it. But what this shows is that the number of places where you can buy tobacco vary greatly based on where you live. So this map is of Durham County, which is in North Carolina. And the dark, it's very hard to see on there, the circles represent the number of tobacco outlets within your community. And the larger outlets, the larger circles represent that there's 9 to 12 tobacco outlets within that community. And the darker blue is predominantly white here. This color here, this lighter blue, is mixed race, I believe, if anybody can see that. And then this is African American, or people of color in the lightest colors. So what you can see is if you live out here, you've got like a few tobacco outlets around you. But if you live here, you've got 9 to 12 tobacco outlets in your community. So this varies greatly within a community. And then it also, as Kate said, that these geographic disparities are often tied to other racial and ethnic disparities and poverty disparities. And so this is a great example of this kind of where you live matters for access to tobacco and also exposure. Because as I showed you the pictures before, that most places that sell tobacco are saturated with tobacco advertising. So not only are you going to be exposed to places where tobacco is sold so you can access it easily, but you're going to see those kind of advertisements even when you just drive by these places. And your kids see them too. Okay, so going out to the last layer here is the state and local policies matter greatly. And again, looking at variations by state, this is the map here is of state excise tax, so it essentially is related to the price of tobacco. And the lowest, the white represents here the lowest, and again, not surprisingly, you know, it's sort of the same. We're starting to see a pattern here of the same states over and over that have highest rates of of use and highest rates of incidence of cancer, lowest rates of policy that could actually decrease these disparities. And then just turning real quickly, and we want to leave a few minutes for questions at the end, but real quickly to some intervention examples. Kate mentioned that, we need to make sure that the interventions that we're implementing are really sort of linked with our conceptual model. And so if we find that our problems are largely at the individual level, we may be wanting to do interventions targeted at the individual level. Often we do multiple interventions, some targeted at the individual and some that are targeted more at the community or that are policy related. So in terms of individual level, certainly education is something that's largely been thought of as an intervention tool, so education within the schools, and then also home smoking bans, so increasing the presence of home smoking bans is often thought of as an individual level intervention. In terms of community level interventions, I wanted to mention the CADCA Strategizer, which is a really nice description of tobacco-free campuses, although it can certainly be used and applied to other areas where we want to promote tobacco-free policies. State and local policies can often be used to increase price, which we know is very effective at decreasing tobacco use. Increasing smoke-free air laws, I'll talk about that in a minute, and then also restricting access to minors. A second community-level approach that's often used is mass media campaigns. So how many people in the room have seen an advertisement or a commercial for the tips from former smokers, the CDC campaign? What about, have folks seen advertisements or PSAs for the real cost? So the one where you pull the tooth out or you rip off the skin, they rip off the skin. So this is another community level approach to decreasing tobacco use. And then I just want to say just take a quick minute. How many people are familiar with the National Tobacco Control Program that's run through CDC? Most people in the room. So this started in 1999, and it funds health departments to support comprehensive tobacco prevention and control. These are the goals that I started with. And I just want to take a minute to talk about preemption. So how many people here are from a state with preemption, or do you know? So preemption is this idea that prevents local communities from enacting local ordinances that are more stringent than or differ from the state's tobacco control policies. So where you live is going to dictate what you're able to do at the local level, and it differs again greatly. The green are the no preemption states, and the others have preemption in one or more of the different categories of things that you can do to prevent tobacco use. So there's a lot that can be done at the local level, but it's going to be dependent on where you are as well. So potentially another example of a disparity, of geographic disparity. So, but in terms of what you can do, expanding smoke-free environments is one thing that often can be done at the local level. So smoke-free policies, we know that they work. There's really good evidence that shows that they prevent heart attacks. They also decrease lung cancer and other pulmonary diseases. There's evidence that they help smokers, they motivate smokers to quit. And then there's really, really good evidence for this last bullet. So often restaurants and bars and other places are hesitant to put smoke-free air laws into place because they are really worried it's going to negatively impact their business. And there's been study after study that shows that this does not negatively impact their business at all, and in some cases it improves business. So there's lots of ways that you can do local policies to improve to decrease exposure to secondhand smoke. So one of the areas that's getting a lot of attention right now, and some of you may even be working on, and that is implementing policies in multi-unit housing to decrease exposure to secondhand smoke. And then another area that's getting a lot of attention, and particularly we're seeing this a lot in North Carolina, and that is restricting outdoor, where you can smoke outdoors. So beaches and parks and outdoor dining areas are areas that are really getting a lot of attention right now. And again, back to our maps to show you how this differs by where you live. What this shows is what can be done at the local level. So the green circles are smoke-free air laws that have been implemented at the county level, and the triangles are implemented at the city level. So in places where there may not have really comprehensive bans at the state level, there's a lot still that can happen at the local level when preemption does not stop you. So finally, we just wanted to mention here that our goal was to set the stage and to talk to you about what geographic health disparities are and how they apply to tobacco and cancer, to introduce the model of how geography can impact your likelihood of tobacco use and cancer. But then we are going to be working with CADCA and the other partners over the coming few years to bring to you some more learning opportunities to address now what. So you've identified these disparities in your community by geography, and so what are the next steps? So we'll be bringing you some more learning opportunities there. But just to give you some ideas, of course, defining the problem within your community. So we're going to hear a little bit about mapping tools that you can use to do that shortly. And then, of course, talking to stakeholders, trying to get access to your state tobacco or your state cancer control plan, which we'll probably, I think we're going to do a webinar on, and then developing a logic model are all ways that you can get started. And CADCA will be providing you with lots of resources for achieving these. So we want to thank you for your attention, and we're happy to answer any questions that you have.
We're going to ask you to use the mic if you have a question, so that we can hear you. And there's a mic right up here.
Thank you very much. I'd like to talk with you about the preponderance of vaping pens and e-cigarettes. We've done all this awesome work, and now people are walking around in everywhere that we've banned smoking with vaping pens.
Yeah. So I think that's a really important question, and one that we could certainly, if that's something that's of large interest, we could certainly spend some time at maybe a webinar talking about local approaches and what can be done at the local level. Business owners, of course, can have their own rules. Some states are putting electronic cigarettes and these vaping devices into state policy, but there's a lot of confusion over what should and shouldn't be done, and there's a lot of voices also being heard in this. So there's a very strong presence of the tobacco industry, as well as the there's electronic cigarette advocacy groups that are strong voices at the table as well. But there are states that are starting to do some stuff around this, and there are areas that are trying to address this. So that it's an important issue. It's one that I don't know if we have a whole lot about sort of how this varies by geography, but we can start to look at that, and maybe we should put that down as potentials for future webinars. How can you address this at the local level? It's a great question.
Hi. In the vein of partnerships in the local community, I had one of my colleagues ask me for some educational resources for cancer prevention targeted at youth. And I'm waiting now to hear an answer back from the CDC, but I hadn't heard an answer, but hopefully somebody can help me with that.
That's a great question. And again, something we'll add on our list, and this is fantastic because we really want to learn from you about what will be the most helpful. So, it's interesting because a lot of cancer prevention is not targeted to youth. The one issue I have seen is on skin cancer prevention, and that is highly targeted towards youth in terms of tanning. I just was thumbing through a magazine the other day, and I saw an ad talking about how beautiful it was to be white, to be very fair, and not be tan. And so I have seen a lot of skin cancer prevention targeted towards youth, but a lot of the other cancer prevention behaviors, probably incorrectly, are largely targeted towards adults, where if we start with youth,
and really establish some of these healthy behaviors, we would get a lot farther in terms of cancer prevention. So that's a great idea. I think we can add that to our list of resources that we'll find and we'll send out through our network.
Okay, great. And I guess just one other question. You know, with the Delaware results and the stage of cancer and the great result of the 50% that we caught early, was there anything about the perceptions of why the other maybe the people are not coming in, maybe they have some kind of values about it's, you know, not worth it or something like that? Was there something about, I hadn't read the article yet, but I will, but I'm hoping to find something in there. But anything that you can mention about that?
You know, that article doesn't talk, I believe, specifically about barriers, but there are a number of fabulous articles out about barriers and perceptions in the community. And the ones that come to my mind as most common are this fatalism belief that why look for cancer, because there's nothing you can do about it if you find it. And then also some of the specific barriers to colon cancer screening are the embarrassment about the procedure, not wanting to do the prep, not wanting to talk about to your doctor about it. And so those are all barriers that I think people are working on addressing. But one important caveat is we will probably never get that rate to 100% just because some of the differences in biology. I think we could certainly get it higher, but we probably are never going to reach that golden target because of cancer and the way it is.
Hi, I'm Rebecca Lepla from New Mexico with the Office of Substance Abuse Prevention. Is there a breakdown on that $8.5 million that Delaware saved? How much of that went back to the state versus private insurers?
You know, I looked for it in the article and it's not in there, but I'd like to understand kind of the economics of that. So I know one of the authors on the paper, and I'm going to ask her if she has any more details about it, because I do think it would be a very powerful case to make to our state policymakers.
Absolutely.
About how the money broke down. Is there any final questions?
Christina Boss, Michigan. Your discussion about smoke-free beaches really hit a chord. I live right on the shores of Lake Michigan, and we've been fighting for smoke-free beaches for over a year with our elected officials. And what I'm wondering is, have communities that have gone smoke-free for their beaches and their public parks, are they publishing anything on how it actually turned out better for them? Because right now, I have a few elected officials who are telling me it's going to kill tourism, and it's going to drive people to the state parks, and they're not going to come to county parks, and we're not going to buy into it. And I've got two people that are completely swaying the vote, and they've been holding this up for over a year. I'd like to give them something a little more concrete.
So that's a great question, and it argues for, you know, that echoes the arguments that we heard when bars and restaurants were, you know, policies went into effect, that it's going to negatively impact business. And so I have not seen anything, and I don't know if anybody in the room has. There's somebody back here that may want to give a comment, but I was going to say I'm happy to put you in touch with some of our folks in North Carolina who are working on this, and so maybe we can start to build that. I don't think that the evidence is there, but maybe we can start. But go ahead.
Thank you. My name is Anna Marie Dufault, and I'm from Yakima, Washington State. And one strategy that the community of Spokane, Washington used, they had this similar concern about smoke-free parks, is there was an event. And so the day before the event, they had they engaged the youth in their coalition to go and look for cigarette butts. And then the day after the event happened, they went and they picked them all up and bagged them up, and they took them to the city council. And that really convinced them.
And I know we didn't have quite time to answer all of our questions, but there's going to be an additional question and answer time at the end of the morning session, and we would certainly be happy to answer any questions individually before lunch break. So thank you so much for your time and for your excellent questions.
Good morning, everyone. How are you feeling? A little chilly in here. I had to get a wrap. I'm Mary Elizabeth Elliott. Please call me Mel. Happy to be the principal investigator on our CDC project that we're exploring with you today. I have the pleasure of introducing our next speaker, and I just wanted to also introduce the CADCA staff that are in the room. So if you're a CADCA staff person, can you stand up, please? And if you're part of this CADCA team, so we have, real quick, we have Karima Abdullah, who is the Vice President for Training Operations and the Director of CADCA's National Coalition Institute. We have Kyrie Smith, who is a lead trainer in our National Youth Leadership Initiative. And we have Alicia Smith, who you've met, and Colleen Hopkins, also on our team. So I just wanted to introduce us, the whole group and say that we are, thank you. Our team is available to you all day. We're just so delighted that you're all here, and we want to make sure you're comfortable. I noticed we have such a crazy agenda today that we haven't left you even a bathroom break. So I want to apologize for that and say, you know, we're all adults, and please take care of yourself. We don't want you to be uncomfortable. We want you to feel good. Now, I'm going to do, because we have so much content, I really just want to give Dr. Fulcher, Chris, as much time as possible. So I'll just say that this man has an incredible repository of data, and he just wants you to use it, and he wants to teach you about all the incredible tools so that you can be empowered in your states and communities. And he's got some new ideas and some awesome data to run through with you today. So I don't want to take any more time, just to say we're delighted to have him. He's an expert. When it comes to geography and public health problems, this is the guy that's really thinking it through for all of us in a lot of ways. So we're just delighted that he could come. And he wants to have a dialogue with you all and show you all of his new tools on his Community Commons site. So please come on up, Chris.
What's that? Are you going to turn it up? Okay, thank you. Good morning. Yeah, and thank you for the invitation to speak here today. And I'm going to go ahead and start with a couple of parts of my presentation. First, we changed the title a little bit to get away from the suggested title. It's really around a public good platform for healthy, sustainable, and livable communities. And I'd like to acknowledge, you know, our team at the Center for Applied Research and Environmental Systems, which is where I work. I serve as a co-director there. And also our nonprofit organization, the Institute for People, Place, and Possibility. And when the introductions were made, I'm not only passionate about making public data publicly accessible, but we have a team of 15 people at the University of Missouri and 6 people at the nonprofit organization that feel as strong as I do. They do incredible work. So what I'm going to show you today is all publicly available. So when I go through the demonstration, you can do this as well. So what is Community Commons? It is a public good utility. And it's really around how we think together, not just from an organization or a foundation or federal agency perspective around obesity or cancer or tobacco use, et cetera, but really from a community context. It's the overlap of many, many different activities. And there's a lot of data. We talk about social determinants data that support that. So we have an integrated nationwide database. We have curated stories and voices, some starter maps, action campaigns, data reports, CHNAs, or community health needs assessments. There's a lot here. And I just ask that when you go to this site, it's a free registration. You know, if you train for a 5-mile run or a marathon, you don't just go on the day of the race and then expect to do well. This is really dense in some ways in terms of how you need to navigate through the system. There's a lot of support videos, materials to help you get through the different parts. Let me just start with a map. And I'm going to do the demo here, and actually I'm going to do the demo from the back of the room, and you all are going to face the front, but it'll work out. This is a map, block group level data, predominant race, ethnicity. We have tens of thousands of GIS data layers in our system, and it's not just about one data layer around predominant race, ethnicity. You overlay that, you overlay poverty, you overlay free and reduced lunch programs, you overlay food deserts, and access to healthy foods, et cetera. So it becomes quite complex when you zoom into a community level, which I'm doing here. As I zoom into San Antonio, you have predominant race, ethnicity on this, where there are predominantly Hispanic concentrations in San Antonio, white surrounding. Then we can split the screen, and you can do all this yourself. I've overlaid on, let's see if I can use this. Here again is the predominant race, ethnicity, and I've overlaid schools. And on this side, I have poverty. The darker that color, the higher the poverty rate. And then I ask the question, I want to look at all schools where the percent of the student body eligible for free and reduced lunch is greater than, I think, 85 or 90% of the student population. So you can do a lot of things with all this public data that is available. One area we have is an area called starter maps. And when I show you the demo, you're gonna appreciate more of the starter maps to ease your way into an area or a theme rather than building these interactive maps from scratch. So we have it, for example, physical environment. We have it around a number of different themes. Another area I'll show in the demonstration are reports, community health needs assessment, our work with CDC, Kaiser Permanente, and a number of other organizations around building this public good tool is to really help nonprofit hospitals as they're going through their IRS process with their 990 form, is to justify their nonprofit status, they need to complete a community health needs assessment. So we've developed a reporting tool to help these organizations as a starting point. We have a team of 5 people working full-time just around data acquisition, data updates. And here, for example, what's new in maps and data, children with over 4 hours of screen time per day, high school graduation rate cohort. There's a long list, and we're having our team update or add new data as needed. We also have on the Commons a data list that you can download as an Excel file. We have tens of thousands of data layers in the system, and this is a shortcut view with the ability to go to, like, say, the civic or boundaries, our city-place boundaries. You can actually click and make a map there, as well as that info button, which is what we call the metadata, the data about the data. So it's really important as we're working with data, who created it, when it was created, and to what level of granularity is that data available. So what we have in place with Community Commons is a global GIS framework. We're working in different countries as well as the US, but in the US, clearly we have many, many data sets, much more than in other areas around the world. So we have free access to thousands of available maps. And it's interesting in the previous presenters showing this, and I'm going to reference my notes here, how geography impacts health, and that diagram there with these different circles, it's really a systems view of community. It's not just around health. It's not just around housing or food. But as we're working with communities, they don't think of sectors. We think in communities of issues, and it has overlapping data. Our government agencies at the federal or state level are very sector-specific data warehouses, and it takes a lot of effort and time for communities to put Humpty Dumpty together. What we're doing at Community Commons is really cutting off that process or that part where people have to spend up to 85% of their budgets, and this is some data I have from Esri, which is a GIS vendor, that 85% of a budget is typically spent on putting together the data, building the engine, putting all the pieces before you even get to doing the analysis and asking the questions. How do we leverage in a public good space the way that people can make access all of this data publicly and then focus on their local and regional data? So around environment, food systems, housing, we have all of the congressional and legislative district boundaries in the US, et cetera. I will show you more in detail what we have with those data layers. So the original title of this talk was Mapping the Problem, Health Disparity by Zip Code. And Dr. Frieden had in that previous slide there it's about your zip code, not your genetic code. And I've been working in the GIS area, or Geographic Information Systems area, for many years, and there's some real fundamental problems with mapping by zip code. It's really good to say, oh, you know your health disparities by zip code, but when it comes to the practice of actually understanding the underlying data, zip codes don't really help out. Why? Because zip codes are not areas with boundaries. They're delivery routes for mail carriers. In other words, it's not a polygon. So we all see in maps, right? How many people see zip code maps as areas and polygons? That's how they're represented. But in fact, they're actual mail routes. So it's not a geographic area, even though we kind of guesstimate that area through the routes that are aggregated. Zip codes are not stable over time. This is a key thing we need to really look at. And in Chapter 3 of this book, Geocoding Health Data, the Use of Geographic Codes in Cancer Prevention and Control Research and Practice, Chapter 3 is using zip codes as geocodes in cancer research. It's very informative, and it really helps us understand, zip codes are not stable over time. They come in and out, they change geographies. So when the health area, when we're trying to look at trends over time, the zip code boundaries are not going to be consistent. It's really important that we have a more stable geographic base to look at trends over time. How many people know their zip code? Mine's 65203. How many people know their census tract code? Yeah, hey, we got a problem here. So we can use the zip code as a way to zoom into an area, but bring up the underlying census tract, block group data, et cetera, that has a more stable geographic base. So it's not just around the health area that they're talking about the instability of zip codes. An article I recently saw about zip code change sought for some residents, the Newcastle Pacer in Oklahoma. Using zip codes to determine tax rates is a mistake because the lack of accuracy. And then they talk about the Zone Improvement Plan, or zip code, was established in 1963 for just the delivery of making it faster and more efficient. And the key thing they say here as well, the Postal Service constantly changes zip code boundaries, making them unstable data sources, according to this website here. So it's a real issue across a number of different sectors around using zip codes. Because what we ultimately want to know is not what zip code we live in, but all the underlying socioeconomic and demographic characteristics, health characteristics that we have. And it's typically ACS data or census data and other data sets that we have available to us by more stable geographies. The one thing about Can you hear me okay? Okay. So another thing about, I'm going to do it again. See that? I'm going to push these in. The thing with the zip codes, as it is an unstable geographic base, is that we often work, and I know working with hospitals, you have these flat file systems where you have a patient, you have an address, and that one column is your zip code column, right? A lot of people just say, well, we're going to aggregate all our data by that last column, which is the zip code. And that's often how we continue to perpetuate the use of zip codes, is because it's one column of geographic data. But what we actually have is the actual address. We have the address. I'm 2712 Bayonne Court, Columbia, Missouri. That's my address, 65203. So what we can do technically is take the actual address, and instead of aggregating and just having that zip code column, we can aggregate our actual address to a stable geographic base like a tract. Now that's something we can work with, and it's technically doable. It's really about how we educate state and federal agencies, nonprofits, of the appropriate way you aggregate individually identifiable addresses and mask it to a population base that gets rid of all the individual address information. I know that's a little geeky techy, but it's really important to not focus on aggregating at the zip code, but at the stable geographic base that we look at health equity, we look at poverty, race, we look at education attainment, all these factors. They're based on census block group, tracts, et cetera. And I know if I got 15 minutes, right, because I want to spend time on the demo and Q&A. The other thing we have on Community Commons are something called curated stories. Because we've recognized working with CDC, Robert Wood Johnson Foundation, with YUSA and other major partners, is that having data and having maps is not good enough. What people resonate with are the stories that are being told. Telling the stories around what works here or what doesn't work there. But what's really important as well, and what we do in the Commons, is with each of these stories, we embed interactive maps and supporting data. So when you go in and look at an issue around food access in Chattanooga, Tennessee, you can actually type in the address of your city and see that interactive map around that story as well. So it's really a way to more resonate with the communities we're working with. We're also involved in action campaigns. So whether it's around Weight of the Nation that we've been working with, this target area intervention tool, and more recently working with Salute America, which is a Robert Wood Johnson Foundation funded effort based out of San Antonio, Texas, working with our colleagues in San Antonio and building these petitions, get sugary drinks out of summer camps. So there's these different campaigns that are also part of what we are involved in. So investing in the commons, there's the public good utility, that's the core of the commons, and then there are a lot of funders that are building what we call hubs, or areas that really focus on different themes. We have a hub around childhood obesity, GIS, with Robert Wood Johnson Foundation, working with the Kellogg Foundation, the CDC, Kaiser Permanente, et cetera. So what is a hub? So here we have, and I'm going to show you this area today, which is Community Commons, the core there. And what we're building around it are these hubs of activities where they're all integrating data and contributing it to the public space. But they're very targeted, they're very mission-driven in terms of what they want to accomplish in these Community Commons hubs. There's a number of, like United Ways, working with Public Health Institute, Kaiser Permanente, et cetera. I show this circle because for many years our center has been developing standalone custom learning systems. In the past, we worked with Robert Wood Johnson Foundation around this childhood obesity GIS. We worked with United Ways around this system called Community Issues Management. We worked with another tool with YUSA, et cetera. So we had all these standalone systems, and pretty soon as we started working with a number of partners, we started getting questions from people who live and work in the communities that are using these different tools. One example is in the Quad Cities area of Iowa. A person working with YUSA said, "Hey, Chris, I'm accessing that GIS stuff you have with our YUSA tool, but I'm also working with United Way, and you've got this community issues management tool over there. I also happen to be working with Robert Wood Johnson on their regional childhood obesity effort." She said, "Why all the disconnect? Where do I upload my data? Where do I tell my stories?" And that was a real aha because we started hearing that more and more. So the birth or the impetus around Community Commons is around aligning investments so we can accelerate learning together, rather than having these separate, different standalone websites. In the private sector, there's a great drive to go to one website versus another. So in the private sector, it's come to me. It's me, me, me. But in the public sector and how we need to collaborate and really how we have limited resources, it should be more about the we. It's how do we learn together. So it's not driving each other apart and trying to find what data is here, what best practices there, because at the community level, there are not the resources, time, and often expertise to put those pieces together. So that's really the idea, the underlying architecture of community commons. What is a hub? A hub is basically a website or front-facing, publicly accessible landing page. And in this area, there's a lot of user roles and security. If there's a community with a group of stakeholders coming together around tobacco cessation, they're pulling together local and regional data, some PowerPoints and documents. They need a private space to do that. And as they're working as stakeholders in that community, they say, now this is the story we want to tell, that can then be pushed out on the public page. So it's really important as we build trust relationships in communities is to provide that back room area for people to help collaborate and think through and best represent what they're doing and making that publicly available. Now this term, we've gone through many meetings around whether it's a hub-led, a group space and all that. It's kind of a funny process, but we've landed on hublets. The reason is, you have your standard hub. Let's use Robert Wood Johnson Foundation as an example. And there are a number of grantees around the country that can be by place, by theme, or issue. It could be Chattanooga, it could be Memphis, it could be other communities around the country. So all the activities that go on in the hublet are aggregated to the hub, the stories, the data, etc. So around community mapping, what I'm showing you in this part of the presentation is the hub areas that funders are working with us to actually capture local and regional data. Are the tools that I'm going to show you publicly available in terms of being able to upload and add local and regional data? No, that is not, because there is, and the concern with the funders we work with is if anybody can just upload data, there could be a lot of noise in that data, and we can't really check for the quality of the data, and it could be overwhelming. But around these hubs, the ability to look at how we integrate local and regional data is key. So exploring smartphones, we're working with smartphone applications to take a picture and actually answering a very simple survey. In this example, it's around safe routes to school. That can all be added to the server in real time. This idea of providing the ability to upload local and regional data is key to what we're doing, our aspiration of what we're doing. About 8 years ago, or 10 years ago now, I presented at a Community Indicators Consortium meeting in Burlington. And my colleague and I were presenting on all this national data, tons of national secondary data. And at the end of the presentation, a United Way president of Charleston, South Carolina, came up and said, Chris, you've got all this fantastic data in there. It's amazing. He said, but it's not good enough. Is there a way that we can upload our local and regional data on top of all this national data you have so we don't have to recreate the wheel, rather leverage that? Because we have a tacit knowledge of our local and regional data. It's more current. A lot of times that local data is aggregated to the state level but never makes it to the federal level. So there's a lot of room here around how we tell a better story of people in place. And so what we've implemented are some self-serve data integration tools. By linking to other web services, whether it's KML files with Google Maps or ArcGIS Server, these are web services. Getting into geeky, techie wording, but it's a way to link to other GIS data layers on other websites. Another tool we have, and this is much more powerful because users are actually able to upload a table, an Excel file, let's say all these addresses of like food banks or food pantries, uploading that along with attributes, hours of operation, tonnage distributed, et cetera, can be uploaded as a table and automatically converted to points on a map. That's one way to do it. A shapefile is a word that GIS people identify with. It's basically like a .doc file or .xls file for Excel. A shapefile is being able to actually upload a GIS data layer, like the boundaries of all low-income residents in a certain area around Section 8 housing or something, so they can look at vulnerable populations as an example. Data that's not secondary, but primary data that's collected at the local and regional level. So that's around community mapping and what we're doing with upload and overlaying that data. So with this approach with the hub, it's not just about uploading local and regional data, but it's about telling the story with that, about bringing stakeholders together to frame the issue. It's really around some people use the word knowledge management system. It's a space for us to work together and then push that out and make it publicly available. And that's the key thing with the Commons. If any data has been created through tax dollars or created publicly, make that publicly available through the Commons. So what we have here is leveraging shared investments for the common good is around how we learn together. How do we accelerate learning by working together? And that's the core of what Community Commons is about. So I read this book a number of years ago. The greatest distances are never geographical. And you think about, I've thought about that quite often as we talk about disparities on one side or equity on another. We talk about our belief systems, our attitudes, our perceptions, and how we relate to each other. It's not an issue of geography. The greatest distance is how we relate in times and how we work together as a society. So I leave you with that in terms of the final slide before I go to the demo. Here's the website, www.communitycommons.org. And what I'm going to do is pardon me, let me slow down. It's www.communitycommons.org. When you go there, it's a simple, free registration. And with your user profile, you're able to save maps, etc. In the live demo, as we're talking about health equity, we've done quite a bit of work, and I type in the word disparity. So you may not be able to read this, but we've created a number of indices around households receiving SNAP benefits, per capita income disparity index, rural versus urban childhood poverty, rural versus urban low education attainment, premature death, etc. So what I'm going to do in the live demo as I go back to the room there is show you first the Community Health Needs Assessment tool, or more appropriately, the Target Intervention Area tool. And a lot of people are using it for grant application processes, and you'll see why when I show that. Then I will also show you the interactive mapping environment. There's so much there. I'm not going to be able to show a lot, but there's cancer data, there's tobacco-related data, there's a wealth in there that you can play with. The challenge is a lot of data is county level, particularly when it comes to health data. And when we all talk about communities and community assessment, we all use county level data, and that's a real, I think that's it should be, a county, not community, if we're going to use that word, because there's so much spatial variability that goes on at the sub-county level that if we use just the number at the county level, we're masking a lot of the equity issues that are going on. So I will go to the live demo. But before I go to the live demo, maybe a couple of questions at the front end on what I presented with the PowerPoint, then I'll go to the demo. Are there any questions right now, or do we want to wait to the very end? Okay. And yeah, I'm hard of hearing, so what I typically do is get close to the person asking the question, and then I answer it, okay? Go here first. I want to give her the mic. Oh, thank you. Thank you.
Celinda Perry, St. Mary's, Georgia. What I'd like to know is, well, I have a problem. I know the zip codes are a problem and they can change. However, individual addresses seems to have some privacy issues with them. So what about a zip+4 system that just puts you in the general area and that doesn't change as frequently?
Right, yes, and when I talk about the individual address, no one will see the individual address. It's from a research standpoint, is how we aggregate that individual address data to a stable geographic base. In terms of a zip code, I think it's great that people type in their zip code. It zooms into geographic area, but it's not the geographic boundary of a zip code that you'll see. Rather, it's a census tract or a block group. So the zip+4, I mean, it's going to be more detailed as well. I mean, that's another option, but again, they're mail routes rather than boundaries. Did I answer your question? Okay. Okay. There you go. One other question, then I'll do the demo part. Yeah.
Hi, is this on? Yeah, Mike Freiberg, Tobacco Control Legal Consortium in St. Paul, Minnesota. You mentioned earlier in your presentation that your software includes legislative districts, but then later mentioned that zip codes are inherently unreliable. I'm just wondering if the same problem exists with legislative districts because of things like redistricting every 10 years, or in the case of Florida, lawsuits.
I think the difference is they're not mail routes. They're the geographic boundaries that are aggregations based on population, based off the census boundary files. And I can't get into issues of, the accuracy of the boundaries of legislative or congressional districts, which is what I think you said, right? But I think it is still a geographic area or base that people work with. Now, a lot of data isn't cut by by congressional district or legislative district. There is also some area estimation approaches when you're using those boundaries, and I'll show you a little bit about that when I do the demo. Did I answer your question okay? Okay. Okay, well, let me run back here and do the demo. Oh, did you close down the, I have to log in again. Okay. Okay, hold on here while I log in. Okay, so what you're seeing is the home page here of Community this isn't, you know how when you play with other people's computers, it does strange things? So I'm going to try to slowly go down. So the Community Commons, first and foremost, is about the stories that are being told. You can browse all Commons articles right here. And as you browse through these articles, like the National Civic Review articles, looking at the reach priority populations, importance of having a safe place to play. And each of these articles has basically a story coupled with the interactive maps. There's videos here. And so there's explanations. And you can read that at your leisure. So the area that I'm going to focus on is around maps and data. When I click on maps and data, there are two sections, the mapping area and the reporting area. In the mapping area, there's this data or data list. When I click on that, what pops up is that file that I showed you regarding that you can download if you scroll all the way down, all of the different data sets we have in the system. I'm going to start with building a report. And there's a tool at the bottom which we're going to promote to the highest level rather than at the lower level, is this Target Intervention Area tool. And this is really has been quite popular as communities not only look at community health needs assessments, but really for grant applications in a number of different sectors. So there's information about the process. Step one, select your target intervention area. why use the tool, how use this tool. Again, a lot of videos and resources, tutorials on how to use these data sets. Step 2, explore your target community more broadly. And then third, community health needs report and additional resources. So let me go ahead, and I'm going to click on create. Let me go ahead here. Hold on here. And I'm scrolling down here. So it's again this mouse, sorry about that. So I'm going to go ahead, community health needs reports, and I'm going to go to Georgia, and I'll go to Fulton County. For those of you in Georgia, what's a county right next to Fulton? It's DeKalb? Wait, what was that? Say it again.
Decal.
Thank you. Thank you. Isn't it great to have a person that can't hear drive? DeKalb. Okay, DeKalb County. So I'm just going to use these two counties right here, and then I'm going to make a report. I'm going to view the report, and what pops up for DeKalb and Fulton counties are these chapters: demographics, social and economic factors, physical environment, clinical care, health behaviors, and health outcomes. So in each chapter, there are a series of pages. I'm on total population right here. And as I click on total population, I'm able to look at by gender, by age group, by race, and that's just one area. If I go to health outcomes, I can look at demographics around cancer incidence, cancer for breast, cervical, et cetera. And there's a wealth of data here. In the interest of time, I'm flying through this very quickly. Tobacco use, if I click on that and I bring up tobacco use, there's a table, a dial, as well as an interactive mapping part. And there's a wealth of data here in the footnotes or methodology around that. If I go to another area, which is called Salute America's, basically growing healthy change, this is more around policy mapping. If I go ahead and I click on this map, this is much more around policies rather than other assets or geographic data like poverty, et cetera. This is around your policy types: active play, active spaces, better foods in neighborhoods, et cetera. And it has at the city, school district, county, or state level. And I'm not sure about the internet. So as I go through and I type in San Antonio, as I zoom in here, there are a wealth of policies: city, school district, county, state. And if I click on a neighborhood area in San Antonio, if I click on that, what pops up are the geographic levels. There are 154 policies in that point that I just clicked on. City policies, state, school district. There are policy types around active play, better foods in schools, healthier marketing, policy stages, whether it's from emergence to development to implementation to policy types. So there's a wealth of information here in the Salute America site. If I click on a complete streets policy to create an active living, it takes you to a story about that policy in San Antonio. It's all the way through the policy spectrum, as well as some related resources there. The final area I want to show, because I have about 2 minutes left, is around mapping. So you can make a map, and in here I could type in predominant race, ethnicity. If I click on that, I add that as a layer. I go to Atlanta, and I zoom in. Then what you can do is add data right here. There's a wealth of data in our system that is broken out by civic and social boundaries, All of our congressional and legislative boundaries, as I mentioned before, are in here. Our political boundaries are in there. Economic data, education data, health data. There's a wealth of health data in the system. We talk about food and food deserts. If we look at access to healthy foods, there's a wealth of data in here as well. So if we click on this, again, I leave it to you in terms of the amount of time to spend in this, but health behaviors, health facilities. One layer I want to show is if we type in, for example, tobacco, a number of data layers related to tobacco that you could look at, or cancer, a number of data layers related there. The key thing is the ability to overlay it with all the other social determinants data. I'm going to move to the front in the last 1 minute. Okay. Are there any quick questions here in terms of what I presented? I flew through this very quickly. I encourage you to look at the videos and spend time just exploring the site. Again, it's a public good utility. Pass the word. We are horrible at marketing and sales because we don't have any marketing or sales people. We really work with our organizations and foundations to help spread the word and make this available to communities around the country. So with that, thank you very much for your time. And I'll answer questions over lunch because in the interest of time, I think we need to move to the next presenter. Or do we have one question or what? Okay, I think we're going to go up front. Thank you.
Okay, so we've got a lot of information so far, and before we go to lunch, I'm going to have our last speaker before lunch come up. Her name is Shantae Keith, and she is from the National African American Tobacco Prevention Network. They're doing a lot of exciting things in the Deep South, and she's here today to speak with us about that. Shantae Keith?
Thank you, sir. Can you all hear me? Great. Well, like Alicia stated, my name is Shantae Keith, and I am with the National African American Tobacco Prevention Network, NAPTN Inc. for short. And so first, just let me say thank you for allowing me to speak with you this morning. Do I have a clicker? Okay. And I wanted to spend a few minutes just to talk to you a little bit about the work that we do and the population that we serve, and how we address disparities among that specific population, especially in the South. And so I do recognize that I am the only thing that stands between you and lunch. So I will try to be brief and be on point. So NAPTN was founded in 2000, of course, to address tobacco disparities within the African American community. And so our mission speaks to how we implement public health programs that benefit communities of color, specifically people of African descent. Now, mind you, our mission has changed just a little because we, of course, have a long history of addressing tobacco use. But just recently, we're refunded by the CDC to not only address tobacco, but also cancer-related disparities as well. And so cancer is a new baby for us, and so we're still learning, along with our network siblings, the Geographic Health Equity Alliance. But some people have kind of don't really understand what exactly the network really does. So NAPTN is not particularly on the grassroots level implementing programs in communities. What we do is kind of serve as a hub of information. So we disseminate information on best and promising practices on how to work with African American communities around tobacco use and cancer. We do that through our network partners. And so, as I stated, the networks serve as this hub of information, and we disseminate, like I said, those best and promising practices, but more importantly, we disseminate information that's more specific to our particular populations. So, for example, I just stated we affectionately call our network members, our partners, our network siblings, and they were also funded by the CDC. To address disparities in their particular population. And so, of course, here today, we are here to support the Geographic Health Equity Alliance, but we also have the Intertribal Council of Michigan, who addresses the Native American population. We have APPEAL, who deals with Asian Pacific Islanders. We have the National Alliance for Hispanic Health that addresses the Latino community. We have Centerlink, who works with LGBT, and we also have the National Council for Community Behavioral Health Care, and they work with mental health populations. And then, of course, you have NAPTN, who addresses, of course, tobacco and cancer disparities in African American communities. So I wanted to briefly share that our board members are strategically placed across the country in different regions so that we can use their connections and their contacts on the local, state, and regional levels to get some of our work done. And for the purposes of this presentation, I just wanted to note that our chairperson, Brenda Bell Caffey, is out of Mississippi, Hattiesburg, Mississippi, is which we classify as part of the Deep South. And so also I wanted to note that we do have 2 offices located in the South. The first is our headquarters, which is Durham, North Carolina. That's where I am. And as stated earlier, if you know anything about Carolina, you know that we are a tobacco state. We are right in the thick of things. We are located in downtown Durham, right in the American Tobacco Historic District. We also have a satellite office in Atlanta, Georgia, and that is not by coincidence. Some of the reasons why we have an Atlanta office is that, one, Atlanta is heavily populated with African Americans, which is the population that we serve, but also the South, or Atlanta, has some unique challenges and health disparities around tobacco use and cancer, and that's where the money is. So CDC is in Atlanta. So it's great to have access to our project officers and work closely with them in the Atlanta area. So for NAPTN, we have several focuses within tobacco and within cancer. And our top focuses in tobacco is that we focus on predatory marketing to our youth, especially at the point of sale, and we also really spend a lot of time on menthol and how mentholated tobacco products has a disparate impact on our community. And for cancer, our cancer priorities are early detection. We focus on getting our people screened earlier. We focus on lifestyle changes, making those necessary behaviors, changes in behavior, such as eliminating tobacco use, exercising, eating right, and we also do access to care. So we work with groups that specialize in patient navigation, which helps patients get the proper treatment and the proper follow-up in their care. And so some may say, well, why the South? And NAPTN focuses a lot on the South. So why do we focus a lot on the South? And the reason is because about 57% of African Americans live in the South. So if you look at the map, I know it's very hard to see, but the dark purple is where most African Americans are concentrated. And so we spend a lot of our efforts in the southern region. And so often we hear terms of the South. We say it's the Deep South. How many of you have heard of it as referred to the Dirty South? Okay. We often also refer it as the Black Belt. And the Black Belt was originally used to describe how rich or dark the soil was in parts of Alabama and Mississippi, but now it describes this broader agricultural region that encompasses most of your southern states. And so the Black Belt has its own challenges. Southern states have high incidences of poverty, rural exodus, where a lot of people that live in what we Southern folk call the country. They're moving to bigger places like Atlanta, Charlotte, Miami, and Dallas and Houston, Texas. The South also has inadequate education programs, low educational attainment, high levels of crime, high levels of unemployment, substandard housing, and poor health care. And so in terms of health care, we know that the South has high rates of obesity. It's also called the diabetes belt and the stroke belt. Because it has high rates of diabetes, heart disease, higher rates of tobacco use, and higher rates of cancer. We also know that a lot of these chronic illnesses that persist in the South are preventable. So the South has a lot of the highest rates of preventable deaths. So they have high rates of preventable deaths among heart disease, cancer, chronic respiratory disease, stroke, and unintentional injury. And a lot of these, as you all know, especially heart disease, cancer, and chronic respiratory disease, a lot of these things can be prevented by stopping tobacco use, exercising, and proper nutrition. So studies show if you live in the South, your life expectancy is shorter and sicker. And so how do we address these disparities? Well, one of the ways we do that is through our strategic partners. And so we have 7 of them. We have 7 strategic partners and 2 consultants that we work with. And for the interest of time, I'll go through briefly some of them and really focus on 2 that work in the southern region. But we have YES. Is that? Okay, we have YES. They're out of Raleigh, North Carolina. They stand for Youth Empowered Solutions. They work with youth around community change and getting youth fired up about tobacco use and how to talk to their legislators about implementing smoke-free policies as well as smoke-free parks and the like. We also have the Intercultural Cancer Council, which is a national organization that addresses cancer disparities within the African American community. We have the National Reach Coalition. They serve as our partners around obesity, nutrition, and physical activity. We also have NOBCO. NOBCO is an organization out of Washington, D.C., and they help us with our elected and appointed officials. And so their membership does a lot of work around menthol as well as clean indoor air. We also have the African American Tobacco Control Leadership Council. They serve as our technical assistance folks on the West Coast. They're out of Oakland, California. And for the purposes of this presentation, I wanted to pull out 2 of our subcontractors making a difference in disparities. They're located in Hattiesburg, Mississippi, and their mission is to eliminate or identify and eliminate tobacco-related health disparities in African American communities in the Deep South region. And so their target areas are Mississippi, Alabama, and Texas. And one of the major activities that MAD does that we're really excited about is that they have implemented tobacco-free church grounds in more than 90 churches. And so this is important for us because we know that the church is still influential in getting folks to be healthy as well as disseminating our messages to a broader audience. And then the other subcontractor that works in the South for us is the Deep South Network for Cancer Control. And so the way we have set it up is that we have, our tobacco partners and we have our cancer. So Making a Difference in Disparities is our tobacco partner that works in the South. The Deep South Network for Cancer Control is our cancer partner. And so their mission is to eliminate the disparity in cancer deaths between blacks and whites in the Deep South. They serve two very important or critical areas for us, the Black Belt of Alabama as well as the Delta of Mississippi. And they do work, they provide cancer awareness activities, they support minority enrollment in clinical trials, and they also try to get minorities to look at other health careers such as biomedical research. And so in order to get their work done, they have some great partners. The American Cancer Society, of course, Susan G. Komen helps them with their breast cancer activities. They have the Alabama Comprehensive Cancer Coalition, the Alabama and Mississippi Breast and Cervical Cancer Prevention Program, as well as the Black Belt Breast Cancer Coalition. And so one of the activities that we're really proud of with the Deep South Network is that they have this train the trainer model. And so they have community health advisors. And what they do is they train women to provide cancer awareness messages and resources to their communities. And so these CHAs are further trained as research partners, and those research partners try to increase minority participation in clinical trials. So currently they have over 300 CHAs, but they also have over 200 research partners. And so they've done some great work in that particular area. So now to the fun stuff. Some of NAPTN activities that I wanted to focus on this morning was that we have a great initiative around historically Black colleges and universities. We also are doing work around menthol on the national scene, and we also have a faith-based summit coming up, and I wanted to talk briefly about that. It's so interesting because they say I have 10 minutes, so I guess I have to speed it up. But our HBCU initiative, it came out of an announcement by the Secretary of Health, Howard Koh, when in 2012 he said that he wanted all colleges and universities to be tobacco-free or have tobacco-free campuses. And so when we looked at that, we saw it as a unique opportunity to look and see where our historically Black colleges and universities stood in terms of having a tobacco-free policy. And what we found was quite striking because we had looked at a list from one of our partners, the American for Non-Smokers' Rights, and saw that there were only 6 colleges that were listed as having tobacco-free policies. Now, why is this alarming? Well, there's 105 federally recognized HBCUs, and to only have 6 to have a tobacco-free policy, we said, well, wow, that can't be right. We have to see if there's some other schools that have policies. And so through some initial calls, we found that 18 additional schools had policies totaling 24 schools. So that may seem low, but I'll address that point in a second. So as you can see, HBCUs are typically located in the South, as well as up the East Coast. And this slide shows that not only are they in the South, but this slide shows that which schools have tobacco-free policies versus those that do not. And so what we did was we formed this core planning team with the Louisiana Campaign for Tobacco-Free Living, Legacy, Campaign for Tobacco-Free Kids, Delta Sigma Theta, the Department of Health and Human Services, and of course us, so that we can look at where our HBCUs are, how we can help them implement tobacco-free policies, how we can help them with enforcement and the like. And so one of the major activities that we did was that we convened this national meeting, this National Steering Committee meeting in Washington, D.C., May of 2014. And the leadership of our National Steering Committee, we're so happy to have her, is the former Surgeon General, Dr. Regina Benjamin. And she was very adamant about having all 105 HBCUs go tobacco-free by 2017, which is a very lofty goal. But we think we can make it. We also did an environmental assessment of all 105 HBCUs. We had contracted with the Morehouse School of Medicine, and we had 5 graduate students do this assessment for us. And what came out of the assessment is we had 40 responses, and 20 schools identified themselves as having a tobacco-free policy. So now we have a total of 44 schools that say that they have some type of policy. And 38% of those schools reported having no issues with compliance. So we thought that was pretty good. But we still have some work to do in those areas. So some of our challenges and, of course, our future outcome is that, one, we need to get a full picture And so that's what we're working on right now, trying to identify those other schools that did not respond to the environmental assessment so that we can see where they are. And then the other challenge is that some of the policies that we pulled, so once they said they had a policy, we went to their websites, we went to their student and faculty handbooks to see what the policy consisted of. And according to A&R, they weren't model policies. So some of the policies had like a one-liner. Well, no tobacco use is permitted on campus. Well, it had no type of explanation of how they were going to enforce the policy and what were the repercussions if you violated the policy. So the other thing is we had some, or we continue to see tobacco industry interference. We know that tobacco products are heavily marketed to our young people and on college campuses as well. And the other thing is that the tobacco industry or some companies fund HBCUs for particular projects and events. So sometimes it's hard for us to get in the door and talk to some school officials because they're funded by the tobacco companies. So again, despite all of these challenges, we are still looking at having all 105 HBCUs having tobacco-free policies by 2017. And so please look for more information on that coming. So one of the issues that I wanted to focus on, and one of our biggest babies, is that NAPTN does a lot of work around menthol. And so you may say, well, why focus on menthol? And just to get a sense of who I'm talking to, all of you are in tobacco control? How many of you are in tobacco control? Okay. So for the most part, you know why. Okay. So you know that overall more than 88% of African Americans smoke menthol. Okay. You also know that 47% of all adolescent smokers smoke menthol. Okay. And so you know that the prevalence of menthol is staggering between our young people, with 72% of African Americans leading the pack in smoking mentholated tobacco products. And you know that that trend goes into young adulthood. And so there was a report that was written by Citizens Commission to Protect the Truth, and it was led by the efforts of the Honorable Joseph Calafino and Dr. Lewis Sullivan. But the report said that it's time to ban menthol, and this report just recently came out. And the report said that if you ban menthol, the likelihood is that there will be a considerable reduction in the number of people that, one, initiate the use of tobacco products. It'll be a reduction in the number of people that will continue to use this product, that will become addicted and develop tobacco-related illnesses or die from tobacco-related diseases. So why ban menthol? Well, we know that Americans, for the most part, favor banning menthol in cigarettes. And if menthol cigarettes were banned, 38.9% of all menthol smokers, 44% of African American menthol smokers, and 64.6% of young adult smokers report that they would try to quit if you ban menthol. Not to mention, if a ban had gone into effect in 2011, researchers estimate that over 320,000 smoking attributable deaths would have been averted by 2050. And so almost a third of them being African American. So we also know that tobacco companies continue to market to our youth. And so it's no coincidence that the top 3 menthol brands that are marketed are the same top 3 brands preferred by our youth, which are Newport, Camel, and Marlboro. And so we also know that the denser the African American population is, the more they are heavily marketed to and the cheaper the cigarettes. So there was a study that was done by the Association of Outlet Density that showed for each 10% increase in the proportion of African American students, the proportion of menthol advertising increased by 5.9%. Not to mention Newport promotion was 42% higher, and the cost of Newports was 12 cents lower. So there was one city in particular that was tired of the marketing to their youth. They were tired of the increase in tobacco use among minority communities, and that city was Chicago. And so Chicago did something that no other municipality had done, which is they had passed an ordinance that restricted the sale of all flavored tobacco products, including menthol-flavored cigarettes, near schools. And this historic legislation reinvigorated the national dialogue on the regulation of menthol, and it has inspired other communities to do the same. And so this is important because no other jurisdiction at any level of government, federal, state, or local, had ever included menthol in the laws that regulated flavored tobacco products. So the buffer zone, as we affectionately call it, it creates a 500 buffer around Chicago schools. It prohibits the sale of all flavored tobacco products. That includes menthol, and it includes your products that are heavily used by African Americans, your Black and Milds, your Swisher Sweets, your blunts, and your wrappers as well. It also tells our children that they are worth public policy that protects them, and it's relevant to our inner city African American and Latino communities, and it also elevated the issue of menthol to the national scene. And so I just want to spend like 2 minutes talking about how Chicago pulled it off. And they pulled it off through community and state input, relationship building, legislative champions, media campaign, and strong partnerships. The first thing they did was they had town hall meetings, and they had 4 of them, which were entitled Reducing Menthol Use Among Chicago's Youth. And so that was a great way to inform the community about menthol and increase awareness about the dangers of tobacco use and bring menthol to the forefront in their community. They also had some great relationship building. So they got community groups to really join the movement. Napton was on the ground at one point talking to pastors. We talked to colleges and universities. We also talked to fraternities and sororities about the ordinance to really gain their support. One of the things that helped us was that Delta Sigma Theta, which is one of the largest sororities that has a great membership of African American women, had recently signed a resolution that they would support a ban on menthol. And so as we were talking to these different groups, that our messages really resonated because they were thinking about how the Deltas supported this ordinance, and so that really helped our message. But having said that, when you do work in tobacco control, we all know that tobacco use has to rise above certain issues. So we know that, tobacco use has to rise above economic development, racism and oppression, other health concerns, diabetes, stroke, poverty, as well as violence. And I highlighted violence because as we talked to the pastors, especially in Chicago, they said, well, we want to help with tobacco use. We feel like it's an important issue, but gun violence is our main platform. And so how do you combat that? Well, we told them the truth. We said that, tobacco-related deaths among African Americans each year is 47,000 versus homicides each year is 8,600. So we don't want to minimalize gun violence. We think that it's a very important issue. But how can we work together to naturally integrate tobacco control activities within the work you're already doing? And so that really seemed to make a great impact with the pastors going forward. And this is us at Chicago State University cheesing. The other thing that helped Chicago out is that they had some great legislative champions. The mayor, Rahm Emanuel, was on board, 37th Ward Alderman Emma Watts, as well as the 16th District Ward Alderman Joanne Thompson. And just a little bit about Joanne Thompson. She served the 16th District, which is a neighborhood called Inglewood. And if you know anything about Chicago, you know that Inglewood is constantly at the top of the list as one of the most dangerous parts of Chicago. But Joanne Thompson started smoking when she was 12 years old, and she smoked for 40 years. So she knew, she took this ordinance personal. Okay, she knew what it was like to try to quit smoking, and she didn't want the youth in her community to go down the same path. So if you can get a legislator that has is personally vested in your efforts, it really does help your outcomes. The other thing that Chicago had going for them was a strong media campaign. They had contracted with this company called Lime Green to launch this public awareness campaign around menthol and how it affected youth and minorities. So the campaign was part of Rahm Emanuel's Healthy Chicago agenda. And so Lime Green was, of course, charged with developing this awareness campaign that included television, radio, and print and creative output. And so these are some of the ads that were very impactful. And as a matter of fact, last week I had a call from one of the people in the city of Chicago that said that these ads really increased African Americans' callers to the quit line by 30%. So these ads were very effective in that regard. And so the last thing I wanted to mention is that the city of Chicago has strong partnerships. NAPTN, we provided them with technical assistance. We were on the phone with them on a monthly basis. As the time came for the city council to really review and vote on the ordinance, we were on the phone with the city of Chicago on a weekly and daily basis. We also, of course, like I stated, we were in the community to galvanize support for this effort. We also had some great partners that provided expert testimony. If it wasn't for the African American Tobacco Control Leadership Council and Dr. Philip Gardner's testimony to City Council, it wouldn't have made it out of committee and ultimately been passed by City Council. So we also used our network to, of course, spread messages to our members, to a broader audience so that we garnered support from around the country. And we also, of course, last but not least, it's very critical, is that we use our network to leverage resources and our partnerships to leverage resources. So you might be saying, well, Chicago's in the Midwest, so how does that affect the South? For us, we are trying to use Chicago as the model. So we are using this model city by city, county by county, state by state. We've seen some movement in Little Rock, Arkansas, as well as Atlanta, Georgia. We're also going to talk to some southern cities, like I mentioned earlier, such as Dallas and Houston, as well as Charlotte, to see if we can get some movement going there. And last but not least, I just wanted to briefly mention that we have a faith-based summit coming up August the 15th, which is vastly approaching, where we're hosting 40 pastors to talk about menthol, as well as predatory marketing to our young people. Like I stated earlier, the church is very instrumental in galvanizing communities around specific issues. And so what we're hoping is that we can get some pastors on board to be our mouthpieces around this issue. And so if you all have your telephones with you, and if you are avid tweeters, I will encourage you to tweet. That's one of the network's goals, is that we are to disseminate our messages, not only through our website, but through our social media. So if you have your phones and you feel inclined to tweet, everybody say, change agent. We all have the ability to make an impact and to make a difference. And so what I encourage all of you today is to be that agent of change, so that we can all work together to eliminate tobacco use, as well as cancer-related disparities in our communities. Everybody say game changer. Chicago changed the game. So can you all. So we're looking for those of you who want to join us in this fight against menthol and, of course, the predatory marketing of our youth. And so if you're interested, please connect with us. And lastly, everybody say end game. We need an end game. And we are looking for strategies from you all and from our network partners, because as we think about, how we're going to have a tobacco-free generation, how we're going to have a cancer-free society, we need all of your input. We need an end-game strategy. We have some ideas. We feel like eliminating menthol is one. But if there are other ideas and strategies that can help us in this fight, we're always looking to partner and to connect with you all. So stay connected. This is our information. If you need some additional resources from us, you can contact us. Of course, visit our website at napton.org. And thank you so very much. It is. If you go to our website, and as a matter of fact, this should be the first thing that you see when you go to our website, and that has all the information for the Faith-Based Summit. We are pretty packed. I mean, we were looking at having 40 pastors, and we're close to that. So if you're interested, please jump on board rather quickly, because like my boss says, he says, well, there is no room at the end. So please, just let us know.
Hi, this is Shauna Shields from the CDC, and I just wanted to clarify, when you speak about the policies at the HCBs, you're talking about comprehensive tobacco control policies. Those are the ones that you're supporting.
Right.
So, and that's what
Right.
you're listing, is the comprehensive?
When you say listing,
When you talk about the fact that you have like 18 or something like that, that you're following, those are the comprehensive, but you looked at others who had some sort of policy, but the reason you couldn't accept them is because they weren't comprehensive.
exactly,
Okay.
because we're following the criteria that's set by American for Non-Smokers' Rights.
That's, yeah, I just
Right.
wanted to make sure there was some clarification there. Thank you.
Oh, no problem, no problem. And so what her clarification was is that we had made some initial phone calls just to see if they had a policy or not. Whether it was a one-liner or whether it was 3 pages, we just wanted to know if they had anything written as far as having a tobacco-free or smoke-free campus. But what we found is that it wasn't exactly a comprehensive or model policy as set by the American for Non-Smokers' Rights. And so what we're doing now is combing through each of those policies to make sure they fit the criteria. And we don't have the numbers yet, but we are certainly working on that, and actually hope to have those numbers by August the 22nd, because that will be our next National Steering Committee meeting. Thank you.